Thank you. So we have a big topic to cover of anxiety. So I'm going to go ahead and just jump right in. I do not have any disclosures today. Basically, my goal is really to try my best to give you a better understanding of anxiety. Try to highlight some of the important elements, review some tools that are really important for evaluation, and give us all a better understanding of both pharmacological and non-pharmacological interventions that we can use in pediatric anxiety. So what is anxiety? I know it seems pretty straightforward, right? But I do think, especially when I'm talking with patients, I want to be able to have a clear understanding of what it is. So it's pretty straightforward here. Worry is anxious apprehension and thoughts focused on the possibility of negative future events. Fear, response to threat or danger that is perceived as actual or impending. I think it's really important to highlight that anxiety can be normal. And we should talk about this with our patients. And as clinicians, it's really, really important for us to distinguish normal, transient, developmentally appropriate worries and fears from anxiety disorders. So anxiety is not all bad. Oftentimes, anxiety can serve a purpose. Some anxiety may help us study. Some anxiety may help us prepare for a talk, right? Some anxiety may support performance. If a bear came running into this room right now, it's appropriate for us to worry or to be fearful, right? If we saw smoke coming into this room, it's appropriate for us to be a bit more alert, to be on guard. You know, anxiety can heighten our sense of awareness in the moment, get your sympathetic nervous system moving and going, and help us activate that system that leads to blood pumping to the right parts of our body to get out of here and to get away, right? So I think we have to always remember that anxiety is not all bad. The issue is when this system that I just talked about is triggered inappropriately. So anxiety is a disorder when it interferes, when it's getting in the way. So these are just a few words that kind of highlight when my patients talk about these types of things. That's how we know anxiety is truly a disorder and we need to do something more about it. I just wanted to briefly highlight, I think everyone knows, we always have to make sure we're not missing something else before we diagnose anxiety. So ruling out these other causes, making sure we ask about substance abuse, maybe do appropriate lab evaluations, review other medical conditions that could be contributing, and a few of them are listed here. A little bit more about assessment. We should always ask about the child's development and their psychosocial functioning. Always getting a better sense of family history as best we can. You know, oftentimes families may not talk about mental health issues, but as much as we can, trying to get a sense of if there's any family history of depression or anxiety or OCD or any of the mental health disorders out there. Getting a good sense of school history and performance will be really important, and ruling out cognitive impairments. To briefly highlight, anxiety is common, one of the most common psychiatric illnesses in childhood. The prevalence rates are about 10% to 30%, more common than asthma, diabetes, cardiovascular disease, and cancer. And I also wanted to highlight that comorbidity is the rule. So all of these disorders listed here often co-occur with anxiety. So we're going to focus on anxiety today, but it's just always important to remember that when we see our patients. Depression in particular, I think up to 60% is what the latest data shows of patients also have comorbid depression. So I'm just going to briefly review some various elements that are listed under this big umbrella of anxiety. So I'll review a little bit of OCD and then the non-OCD anxiety disorders. I'll go over some tools for assessment, treatment, and these last two diagnoses I want to highlight, they're not necessarily anxiety disorders per se. They're actually separate, but I think we often talk about them under the umbrella of anxiety, so I was going to highlight them briefly towards the end of my talk today. And then finally, I'll review some resources for parents, kids, and clinicians. So here's OCD. I think what's most important to highlight here, when you have someone who is diagnosed with OCD, they can have the presence of obsessions, compulsions, or both. So it can present in a variety of different ways. Also, the content of the obsessions or the compulsions can vary. They can be abrupt or insidious. There can be a precipitating event or maybe not. Could be chronic or severe exacerbation. So it can vary. And this is just a brief outline of what an obsession is. So I won't highlight it in detail. I mean, you can see it's an intrusive, unwanted thought, urge, or image that can cause significant distress. To briefly highlight, this is the definition of compulsions, repetitive behaviors. So examples here are hand washing, ordering, checking, mental acts. So sometimes you may not see the compulsion, right? So it could be a thought, praying, counting. I wanted to highlight that young children may not articulate these compulsions, but they'll be there. What's most important, I think, to highlight is that it's time consuming. So like I said earlier, there are a wide range of clinical presentations that can exist, but the fact that it's time consuming, so taking more than 1 hour per day, is very important to highlight. Also that it may cause clinical distress or impairment. Like I said, these are disorders, so they're going to impair functioning in some way. It's hard to give estimates when I was thinking about OCD, but the data out there says about 1 to 3.6%. Because I think oftentimes we need to make sure we distinguish between, there's a broad range of mild rituals and obsessions that can occur as common experiences throughout the lifespan and as a developmental phenomena in toddlerhood. So that's the estimate right now. And it's frequently associated with other anxiety disorders, so tics, including tics, mood disorders, and attentional problems. Generalized anxiety. So what's most important here, just to highlight briefly, is that it can occur in a number of areas. There's a lot of excessive worry, apprehensive expectation, occurring more days than not for at least 6 months. And then along with that anxiety and worry, there can be, in children, you only need one of these listed, if you can see it with the second bullet. But there's some other associated physical symptoms. So muscle tension, irritability, difficulty concentrating, being easily fatigued, feeling restless or keyed up, and a sleep disturbance. I mean, briefly, these are kids who are often really perfectionistic, may have unreasonable expectations regarding their own performance, often self-critical of themselves. Maybe that all or nothing thinking may be present. Just a few examples of what generalized anxiety may look like. I won't read through the whole thing of separation anxiety, but basically what's most important to highlight is developmentally inappropriate and excessive fear or anxiety concerning separation from the attachment figure. So there's different examples listed here. So some kids may have excessive nightmares about something happening to a parent or a grandparent or some other attachment figure. Refusal to go to sleep away from that parent. Maybe repeated physical complaints when separated from a major attachment figure. Just a few examples. Specific phobia. Specific phobia is basically a fear. In children, the fear and anxiety may be expressed by crying, tantrums, freezing, or clinging, but it's marked anxiety or fear about a specific situation or object. I mean, so most of us may have some, I know a lot of people are afraid of spiders, but in the clinic we see lots of different phobias or fears that may pop up. This highlights just some of the DSM-5 criteria here. Again, in the interest of time, I won't go through all of it, but a phobia is one type of anxiety that we should always think about. It's common. Often people may present with multiple phobias, so sometimes it's always good to ask about, if there's more than one phobia. Panic attack. Panic attack is an abrupt surge or intense fear or intense discomfort that reaches a peak within minutes. And you have one of these 4 symptoms along with it. Panic disorder is when we have recurrent panic attacks. So we just briefly kind of highlighted what a panic attack can look like. Disorder is when people have unexpected reoccurrent panic attacks. And there's often persistent worry about additional panic attacks and their consequences and significant maladaptive change in behavior related to the attacks. I wanted to highlight that panic disorder is not that common in childhood. There are a small number of cases that do begin in childhood, but usually the typical age of onset is around 20 to 24 years of age. But we often will see, when you get the history, you will see that this presented early on. So there were some fearful spells or things that popped up early on. Briefly, selective mutism, failure to speak. So these are kids, we don't see this that often, but these are kids who won't speak in specific social situations. Although I think it's important to highlight that these kids are able to speak in other situations, so there are no other, we should always assess for other communication disorders or difficulties, but these kids will not talk in certain settings. I think it's also important to highlight that the failure to speak is not because of a lack of knowledge or comfort with the spoken language. And we always want to rule out other disorders, which I already talked about. How to assess. So of course, we always want to interview the patient, get collateral from the family. As I mentioned earlier, we always want to ask about family history. I think it's, if possible, it's always good to connect with the school, get some sort of history from the teacher or from the social worker in the school, and get information about the patient's personality, functioning, developmental adaptation to family, school, and social environment. So these are a few metrics. I just highlighted a few. The one up top is the most, is free and widely available to most primary care physicians out there. But this is a list of other metrics. I think metrics can be really important and very helpful for screening. Some of them are used here for screening. Some of them are used to kind of, we would follow them over time to get a sense of how things are going. If the treatment that we're providing, is it getting better or is it getting worse? So if you can, it's really great to get metrics in our patients. In general, these are the treatment guidelines that we want to think about. So especially, I think I was initially thinking about OCD with this, but it's the same for anxiety as well. So CBT or CBT and an SSRI, so combo treatment, you'll hear that a lot, or an antidepressant or SSRI alone. We always involve family if possible. I think it's super important to not forget that fact. Having family involved can help destigmatize the overall diagnosis and treatment. It can help us to reframe symptoms. Oftentimes these kids are coming in with other, it may not look like anxiety, but there's other problems going on or conflicts or disagreements, and having the family involved can kind of help die down all of those other associated symptoms. And it can really encourage treatment alliance. We want to make sure our patients engage and follow our recommendations. And there's also some great family support groups out there as well that can be really helpful. So I'm not going to, because of the time limit, I'm not going to go into too much detail, but there are a few studies, and some patients like to hear about these studies. And so if we're talking about OCD, I think this one is a good one just to be familiar with briefly. So this study, the Pediatric OCD Treatment Study, or POTS, is what we commonly call it. The goal was to evaluate the efficacy of CBT alone, sertraline alone, or combined treatment as the initial treatment of OCD. So patients were assigned to these 4 arms, so CBT, sertraline, combined, or placebo, and for 12 weeks. And there were a lot of great outcomes. I think what I want to highlight the most is combination. So if you look at the graph, the one that's the lowest, the black square, was combined treatment. Treatment emergent adverse event. So I just wanted to highlight this because with the treatment of OCD, there was no treatment emergent suicidal thoughts in this study. So I just wanted to highlight that for OCD. But these were the most common adverse events that did pop up. And this is the basics of the pharmacological treatment for OCD. So clomipramine, which is a serotonin reuptake inhibitor, and then you are probably familiar with all of these SSRIs. These are the ones that we typically think about. Briefly with clomipramine, most extensively studied in children. Adequate trial is around 3 mg per kg per day for 3 months. We always have to monitor for side effects. So the most common side effects we often need to think about are the anticholinergic and antihistaminic side effects. It can cause tachycardia, so sometimes we think about getting EKGs with clomipramine. Often we'll get like a baseline EKG and then get one later. SSRIs, this is probably the first line, what we typically think about when treating OCD. Back in the day, we always used TCA, so there's a distinct advantage once these types of medicines came on board in terms of the side effect profile. The most common side effects are listed here. Sometimes, especially in the first few days, a lot of kids may complain of GI distress. So maybe some mild nausea, like mildly loose stools, stomach aches, headaches, tremor, drowsiness, feeling really restless, akathisia, or feeling really restless, kind of having the need to move. Enuresis, insomnia, agitation are some of the most common ones that we want to talk about and watch for. I think what's most important is that we want to make sure that we get an adequate trial of an SSRI. So especially when people are anxious, like a lot of people are like, oh my gosh, it's not working, like they're really anxious and they want a quick fix. And we kind of have to always remember, just to encourage patients and families to hang in there with the medicine, may need to give it time. Overall, people say about 6 to 12 weeks is kind of like what you need to think about to determine if a child is a true responder. I think what's most important is that we just start low, depending on the case and the situation. Go slow and keep going is what we talk about when we're working with SSRIs. So making sure that they can tolerate it, but we want to slowly titrate up to the appropriate dose and giving it a solid amount of time to see if it's going to work or kick in. So what do we do if it's not working? If there's still lingering anxiety or OCD symptoms there? Remember, we haven't talked about CBT just yet, but there is CBT out there. And so encouraging families to engage in evidence-based treatment for the therapy piece is really important. We can always switch to another SSRI. And again, this is sometimes just a thought that maybe you may want to ask about family history. Sometimes if one SSRI worked well for another family member, it might work well for the child. And then we can also think about clomipramine. So switching to clomipramine or augmenting with an atypical antipsychotic is another option to consider. If there's treatment refractory OCD, these are some options to think about. You know, these are some options that are potential. We can either augment and add to, or we can switch to these. A quick note that I wanted to talk about with benzodiazepines is I'm not a big fan of using those in children. If we do use them, I usually go with clonazepam, and it's a very low dose, and and it's scheduled, so not as needed, and it's short term, and I give that message early on. So I set the message that this is not going to be forever, this is short term. In certain cases, I mean, clonazepam is totally appropriate, but most of the time we try our best to avoid benzos. It's not the best treatment for anxiety in children. And this is just a brief highlight of non-OCD anxiety. Again, it's similar, right? We have the evidence shows that CBT is really important, and then we always want to think about SSRIs as well. Things to consider. So of course, we always want to think about family preference. We want to work with families and make sure that we are on the same page as the family. We have to meet them where they are. Thank you. And then cost and treatment availability. So sometimes CBT is not available, so we got to work with what we got, right? This is just, this is an article that just came out last month, and I figured I'd just throw it in here. I just kind of took a screenshot of what I saw. This was in our big journal, our Journal of American Academy of Child and Adolescent Psychiatry, and it basically highlights the importance of SSRIs, and that SSRIs, more so than SNRIs, can be really helpful for the treatment of pediatric anxiety, and that sometimes we may see improvement sooner than the 8 weeks that I listed earlier. So I just wanted to highlight that. This is another study that is big in the child and adolescent field. Again, I won't go into it because of our time constraints, but it's something to think about if you want to get more information about how we treat anxiety in children. And I just want to highlight again that combination is the purple line. So combination works best. SSRIs, very important to talk about this. A meta-analysis showed no reported suicides. In depression, and this talk is about anxiety, but we talked earlier, right, that there's a lot of comorbidity. So I just wanted to highlight that in depression, there was a slight increase in new onset suicidal thinking. In those 2 big studies around anxiety, there were no suicide or homicide attempts, and even one study suggested that CBT may be protective. But again, this is in depression. So I just wanted to highlight that. I know that's often a big question that pops up when we're talking about SSRIs and treatment of anxiety disorders. And again, if it doesn't work, these are some other options to consider. CBT. I know we throw it out a lot. I often will draw this triangle on the board when I see patients and kind of highlight for patients this triangle, pointing out that our thoughts can lead to our emotions and our behaviors, that they're basically all connected is what I point out. And sometimes we'll even go through examples in my office. So for example, just briefly, a hockey player is on the ice and he's panicking, he's having a panic attack, right? We know there's no other, we did a full evaluation, there's no other cause for his panic attack. We can work with that hockey player to change his behavior. So instead of leaving the ice and freaking out and thinking he's gonna die, we can encourage him to stay on the ice. Or we may work with him to change his thoughts about that feeling. So that's a little example of what CBT, like a little primer in terms of what CBT is about. But working with kids to change those behaviors or change thoughts to address their specific anxiety disorder. School refusal, not a DSM diagnosis, but it often pops up, especially when I work with a lot of collaborative care settings. The symptoms are associated with several diagnoses. We should not include kids who are not going to school because of truancy or conduct disorder. And the picture can vary. I think what's most important to highlight is that we want to make sure we're not negatively reinforcing behaviors. So for example, like they may be avoiding school because of bullying, or maybe they're scared of reading out loud. But we also don't want to positively reinforce, so letting kids stay at home and do pleasurable things at home is also really important to think about when these cases pop up. Treatment varies, but we should always make sure that we involve the school. And then PTSD. We just have a few more minutes. I'm just going to briefly highlight PTSD because it's a huge thing that's often showing up in our clinics. I wanted to highlight first that if we do diagnose PTSD, what's most important is that we figure out, have they actually witnessed something? So the first criteria here, criteria A, talks about threatened death, serious injury, or sexual violence, and they've either had direct experience, they've witnessed it in person, or they learned about the event occurring, or they've had experience or repeated extreme details of the event over and over and over. So I think that's really important to think about before we even start thinking about PTSD and its treatment. These are some other symptoms. I'm sure these may sound familiar. Memories, dreams, flashbacks, distress when they're exposed to a reminder of the event, physical distress after a reminder of the event, avoidance, and negative changes in their cognition or mood. So poor memory of the event, negative beliefs towards self-blame, persistent negative emotional state, loss of interest, detachment, and lack of positive emotions. Also, feeling irritable, reckless, exaggerated startle. What's most important is that they get evidence-based treatment. So that was trauma-focused therapies is first line. And this is just a little bit about what it looks like. These are some other evidence-based treatments. Again, these are all trauma-focused therapies. I think what's most important to highlight for this setting, therapy, and trauma-focused therapy. There's a little bit of data about medicine. I mean, I'm just highlighting here a few different medicines. What's most important is that we only start medicine if there's clear pre-trauma comorbid conditions that are appropriate for pharmacotherapy. So I want to make sure that I'm giving a medicine that is treating some other comorbid issue as well, and not necessarily just the trauma symptoms. So don't forget to ask about it and encourage therapy. So I'm about to wrap up. These are just a few books that I have here that are really good for you, for kids. Some of these are children's books, so like you can read, they give you tools and tips about how to treat anxiety. Parents and providers, these are some great websites here that talk about ways to treat anxiety. And we've already talked about it briefly, but the Michigan Child Collaborative Care Program, MC3, is an option as well to think about if you ever have a case that you want to talk about, get guidance on diagnosis and treatment. We are here. There's the website. Feel free to reach out to the website if there's other questions. And thank you. All set.